So as I said earlier, we get, hopefully that'll work. Hopefully it's full screen. Can you see that?
Yeah.
Yeah. So as I said, we get a download from our NWAS colleagues on a weekly basis now, and this feeds into our real-time surveillance analysts. We collect the data across the whole of the Northwest, so it's not just Lancashire South Cumbria. We also have it for Cheshire and Merseyside and GM. So what we do with the data is we're aligning it with our RTS suicide, suspected suicide information as well. We're splitting the data in a number of ways to feed into different governance structures that are being established in the ICB. So this is based on those that are ringing 999, looking for a 999 response across our Northwest system. So the data in front of you here is for under 25s because of the way we've split it for our governance structures in Lancashire and South Cumbria. So we've cut the data 0 to 25 to support the transformation work with CYP services, aligning to the NHSE long-term plan. We've got it from 18 and above, so there's a bit of double counting in some of this data because we've counted 18 to older adults, and then we've cut it 65 and above as well. So what we get is the how NWAS are coding the information.
Yeah.
So you can see there, as I said, there's about 150 different codes within NWAS. Every ambulance service is slightly different. So, you know, our biggest area for our 0 to 25s is threatening suicide, intentional overdose. You know, we can see it where they've tried to resuscitate, where people are dead on arrival, etc. So it's really, you know, valuable data.
There is, because I'm a boring researcher. I'm just going to ask some boring research questions, but they're important in terms of what the data means. So how is that data coded? Is it me, if I'm the paramedic attending, I'm entering a clinical code into the system?
It's the call handler on the call, and then you'll have a stop code at the end.
Okay, so I'm the call handler and I get a call through from someone to say, yeah, I'm feeling really bad and, you know, I've taken some paracetamol tablets. I then code that on the system, do I, as a call handler? And can I just ask as well, obviously you've got the intentional overdose codes there. What about injury codes? Do they, you know, if someone's cut themselves or something, would they have those as well, or? Yeah,
they have that as well. They have like ligatures. They have that. You know, it's a vast. We've got a whole data set. So you know, Nav, we can share that with you, and you can have a look at it.
But it's the call handler making the judgment about, and they're taking that directly from what the caller has said, basically, aren't they? So.
Yeah, and then you have the stop code at the end. So it's, you know, where you have see and convey, see and treat, hear and treat. So we understand. So as a system, we can say, well, I'll show you here. We can see the volume of people that are being conveyed to into A&E. So of those 0 to 25-year-olds, over 2,000 were conveyed into our acute setting. We can see the volume that was seen treated at home. This no outcome is a bit of a red herring, because actually when you break that down, you can then really unpick. You might have police dealing with the incident, so we can see the demand on our police services. You know, so that one, you know, we always flag that and say there's lots, you know, we need to unpick that overall code. And then we can see, we break it down by the category of call as well. So a Cat 1 is a life and death situation. A Cat 2 is normally a 17-minute response time. Obviously during COVID, that was dramatically increased. And we have that across the board. We split it by CCG area. So it's all about supporting those improvement plans, looking at our demand. Where do we need to put more resources? What we do want to do is cross-correlate this information with the acute data. You know, are they coding it correctly, etc. So we can do that triangulation. Helen's working with the schools, because what we want to be able to do, we have Operation Encompass across the Northwest. So when there's a domestic violence incident and a child is involved, the schools are notified. What we're trying to do is see if we can extend that for self-harm. So when somebody, like a young person, self-harms, can we then notify the school? Because obviously the school is a really vital support system that we can actually access other mental health services. So that work's also underway as well. But that's how our data looks. You know, we're able to then look at, you know, how we want to use this. So for Cheshire and Merseyside, for example, I'm using this data for looking at crisis, looking at our crisis services, looking at bringing this into our as capacity and demand, making sure that our 24/7 crisis services are adequately resourced to meet the demands, because ultimately those patients that are sat waiting in a Cat 3 to Cat 5, they don't need to be in an MWAS stack. They should be coming into a mental health system. They should be, you know, being addressed by those mental health practitioners and taking that demand away from our NWAS colleagues. So that's the way that we're starting to use the information. We can map it because it's non-patient identifiable information. We've now extended the postcode, so we're getting 4 digits or 5 digits of a postcode. So we can start mapping it as well, because that was a recent change. But it's really good.
It's brilliant. It's really brilliant. Is that something that every area of the country would have, you know, that have the data from their ambulance service, or is this particular to North West Ambulance Service?
I'm not aware of any other area that has it.
Okay.
We've obviously got great links with Craig and you know, in NWAS, and we've worked with them on this. You know, I think being one of those first areas within the suicide prevention program has really helped us to move the RTS data forward, and that's why we're then adding other data sets into it.